So good afternoon, and once again, welcome to this meeting of the Clinical Excellence Program, which we're holding at AIIMS in collaboration with the Ministry of Health and Family Welfare. And as you all know, these are interactive webinar series, basically between regional and state centers of excellence to really promote COVID management guidelines right up to the peripheral level. Before I start, and we're going to cover remdesivir and other antiviral agents. And before we start that discussion, I'd ask Shri Love Agarwal from the Health Ministry just to give the introductory remarks.
Thank you, Dr. And at the outset, let me welcome all the participants for this webinar today, along with our colleagues from AIIMS. I think besides a bigger focus on oxygen and its usage, remdesivir and antiviral is another most important topic in front of us. What we would particularly like to highlight from Ministry's point of view is that for some reason, I think a message has gone down into community that remdesivir is like a magical bullet. I think it may have relevance, but it has relevance at a particular time for a particular set of patients. Sometimes, if we do not really understand when a medication has to be given, we may even come to a situation where we may actually end up harming a patient. So to that extent, we feel that it is one of the most important webinar wherein our colleagues, senior colleagues from AIIMS, they have joined in, and our regional center of excellences along with the state center of excellences are working together. While we are going to discuss about this, I would also specifically like to highlight if tocilizumab and other issues also can be discussed, because yesterday, as Dr. Guleria did mention in one of the state workshop, that it is actually not needed, there are alternatives available. So be it remdesivir, be it tocilizumab, other antivirals, what are the other options available so that the type of scare which is created around in the system can actually be avoided, and something which is easily available and equally important can be provided to patients. This will help in a large way in terms of panic management, misinformation management, and these webinars are part of that series. Last request I would like to make to all our colleagues from Regional Center of Excellence and State Center of Excellence is that kindly start working out in collaboration with your states the district level training plan of action. Idea here is to go down to masses. Idea here is to demystify COVID-19. It is also to ensure that every health professional in the country understands this disease. When the trajectory is moving towards tier 2 and tier 3 towns, it is imperative that we actually go down to every health professional in the country. So with these introductory remarks, let me pass it on to Dr. Guleria, Director AIIMS, to kindly take it over. Thank you, Dr.
Thank you, Sri Love Agarwalji, and welcome to all the faculty which are here from various regional and state centers of excellence. Today, as has already been said, we're going to really discuss a very important topic, because this is something which has created a lot of, let's say, hype in both among doctors and in the media itself, and that is remdesivir and other antiviral agents. We should understand that unlike various other viral infections, we actually don't have an antiviral agent as far as COVID-19 is concerned, which is specific for COVID-19. What we have is currently repurposed drugs which we feel have an antiviral action. Even remdesivir was actually made from the Ebola infection point of view. It was not a primary drug as far as COVID-19 is concerned. We don't have really good antivirals. We do have monoclonal antibodies, and they are now being introduced into the country. One company has now tied up and has also got the emergency use authorization for monoclonal antibodies. But even monoclonal antibodies which are available have been approved only for mild illness, and it's a little bit of a challenge about giving them for patients with mild illness, because it's given through the parenteral route, and cost is also an issue, because even if you look at what the company is looking at the costing in India as compared to what it's available in the US, still it's going to be a prohibitive cost. So I don't think that they will have a really big role to play in our country as of now. But there is a lot of hype around remdesivir, and I'm sure we'll be able to discuss that today. The unnecessary hype and how much useful is it in terms of decreasing mortality, in terms of decreasing hospital stay, and what are the other antiviral drugs which we can think of or which may be useful across the board. But I think it's important to remember that this is something which is of great interest, not only to doctors but also to the general public, and therefore it's important that we, as was said, demystify the treatment of COVID-19. Today, to talk on this, we have a faculty from the Department of Medicine, Dr. Animesh Ray. He would be speaking on remdesivir and other antiviral agents. And on the panel, we have Dr. Anjan Trika, from professor. He's a professor from the Department of Anesthesia, Critical Care and Pain. Dr. Manish Suneja, who's a professor in medicine, and Dr. Neeraj Nishchal, who was there yesterday also and for the last few days. So I'm really grateful to all three of them for being here as panelists, and to Dr. Animesh Ray for agreeing to give the talk. So without wasting much time, we'll go on to the talk. And of course, Dr. Rajiv is there to sort of moderate the questions once we finish the talk. So over to you, Dr. Animesh Ray, for the talk on remdesivir and other antiviral agents.
Thank you, sir. So is my screen visible and my voice is audible?
Yes, yes.
Thank you. Thank you. Good afternoon, everybody. So what I'm going to do is, over the next 15 minutes, I'm going to talk about remdesivir and other commonly used or encountered antivirals as far as COVID-19 is concerned. So just briefly introducing the subject, antivirals is one of the 4 commonly used group of drugs, apart from anti-inflammatory, anticoagulation, and supplements. So what I'm going to do is I'm going to enlist the commonly used antivirals. I'm going to talk about them individually, their indication, contraindication, and other paraphernalia which are used, which would be required for one when they are using it. And then I'm going to move on to some around 10 FAQs, frequently asked questions, so that we can have a good discussion about that later on. So talking about antivirals, so these are more or less the list of drugs for antivirals in COVID-19: remdesivir, Favi Pyrovir, Ivermectin, HCQ, convalescent plasma. I think 3 days back we had a good discussion regarding it, and some other antiretroviral drugs like lopinavir, ritonavir, and molnupiravir. Now these are the 4 common drugs that we get to use in India. Some with indications, some out of indications. So I would be concentrating mainly on these 4 antivirals. Right. So talking about remdesivir. Now, as Professor Guleria sir was saying, that remdesivir initially was used in Ebola, and before that in hepatitis C. Now it has been repurposed for use in COVID-19. It mainly acts by inhibiting viral transcription. Now, what is important about remdesivir is to understand the indication of remdesivir. Now, the indication of remdesivir is it is mainly used for treatment in adult and pediatric patients. By pediatric patients, I mean all those who are more than 12 years of age and weighing at least 40 kilograms. And this is the most important part. This says that remdesivir is used only on those patients who are on supplemental oxygen, who do not require high flow oxygen or ventilatory support. So if you look at the figure to the right, so we have the spectrum of COVID-19, starting from asymptomatic, mild, moderate, severe, critically ill, where moderate means, as we know, saturation is between 90 to 94%, respiratory rate is between 24 to 30. Severe means that the saturation has fallen down below 90%, of the respiratory rate has gone above 30. And critically ill means that the patient is having severe ARDS, sepsis, or severe ARDS, sepsis, or multi-organ dysfunction. So within asymptomatic and mild, there is also some subcategories where the patient is not having any much symptoms, or the patient's oxygen level is otherwise normal, but there are increased inflammatory markers, and or the CT scan is showing significant lung infiltrates. Now, as far as remdesivir is concerned, it works only in those patients who have moderate and some people of severe COVID-19. So all those people whose oxygen level goes down, remdesivir, it has been shown that it might be beneficial in this particular group. How beneficial? In this particular group, it might decrease the number of deaths, and in this particular group, it might decrease the time to recovery. So these are the two benefits which can be expected out of remdesivir, but only in this particular, in this particular subgroups. So for all those patients who are on HFNC, high flow nasal cannula, or non-invasive ventilation, or invasive mechanical ventilation, remdesivir in any of the trial has not been shown to be beneficial in terms of either decreasing mortality or reducing time to recovery. So that is something which we need to bear in our mind. Talking about dose and duration, I think we all know this: 200 milligram first day followed by 100 milligram. Typically, it is used for 5 days. It may be extended in patients who are on mechanical ventilation or ECMO, or when the clinician feels that there has been incomplete improvement by day 5. It is always given intravenously, and it is administered. It is obtained. Usually it is. Remdesivir, we have lyophilized powder which has to be reconstituted in normal saline, and it is typically administered over 30 to 120 minutes. Regarding the contraindication, the absolute contraindication is hypersensitivity to remdesivir or any of the components. If the patient is having an estimated GFR less than 30 or increased transaminases more than 5 times at least, then that really precludes the use of remdesivir. Regarding side effects, some of the common side effects seen are increased transaminases, nausea, rash, hypersensitivity, and in some cases, some cardiac events like bradycardia or hypotension. It has significant interactions with chloroquine and hydroxychloroquine in that it diminishes the therapeutic, in that chloroquine or hydroxychloroquine has been shown to diminish the therapeutic effect of remdesivir. So co-administration is not recommended. And if the patient is either pregnant or breastfeeding, then remdesivir is to be avoided. Regarding hepatic dose modification in hepatic impairment, if the patient develops increased transaminases, after starting remdesivir, and if it is increased more than 5 to 10 times, then you have to discontinue therapy. Or if the patient is having features of hepatitis with transaminase elevation, then also that's an indication for discontinued therapy. As said, if the patient has low eGFR, then remdesivir is not recommended. Right. So talking about Favi Pyrovir, now Favi Pyrovir has been used as an antiviral in COVID-19, but again there isn't much evidence. So we'll just talk about it briefly. So this is one of the medications which have been used against influenza. It is approved for the same use in Japan. It also acts more or less in the same manner as remdesivir by inhibiting RNA polymerase of the virus. It is not indicated in COVID-19 as per the AIMS and ICMR joint monitoring group guidelines. And for that matter, it is not indicated, it is not approved for treatment of COVID-19 in any of the international guidelines. But however, we commonly see that favipiravir is used in a lot of patients of mild or moderate COVID-19. But that again is not to be encouraged because, as I said, no studies till date show its benefit or effectiveness in any patients of COVID-19. There are several problems with favipiravir. One, obviously, the most important being lack of evidence. The other being significant pill burden. So a lot of tablets over 7 to 14 days, and it cannot be given in patients having renal impairment or severe hepatic impairment. It also has some significant drug interactions. Also, the other problem with favipiravir is there are significant side effects which can be seen. So starting from increased uric acid, increased transaminases, nausea, there can be a host of side effects which can be encountered when one uses favipiravir. So within contraindication, hypersensitivity is a contraindication, and again, it is not supposed to be used in pregnancy or breastfeeding. Talking about ivermectin, is again one of the repurposed drug for COVID-19. It's a commonly used anthelmintic agent. Regarding indications, the AIMS ICMR Joint Monitoring Group guidelines, they mention ivermectin as one of the may do's in mild COVID-19. But we have to be clear that till now there isn't much evidence showing that ivermectin actually works in any form of COVID-19. But again, as far as my understanding goes, it has been included because one is that ivermectin, some in vitro studies have shown some antiviral activities, and as such, it is considered to be a safe drug. So it's probably because of its innocuous nature that it is included as a may dose in mild COVID-19. The dosing is again 200 microgram per kg for a 60 kilogram adult. It would be around 12 milligram once a day for 3 days. It has got no dose modification either in renal or hepatic impairment. Pregnancy and breastfeeding, one should avoid ivermectin. Hypersensitivity is a contraindication to ivermectin, and some side effects commonly seen are pruritus, rash, arthralgia, diarrhea, nausea, or even increased transaminases. It has got interaction with warfarin. So if somebody is taking warfarin, ivermectin, it can enhance the anticoagulant effect and chance of bleeding. So it is something which we should be keeping in our mind. Talking about hydroxychloroquine, again, it has been used in a number of conditions, antimicrobial, autoimmune diseases. It is also thought to have some antiviral action. So initially there was a lot of enthusiasm surrounding the use of hydroxychloroquine. Again, just like ivermectin, this has been included as a may dose in mild COVID-19, again, because it's thought to be a relatively safe drug. But again, no studies till date have conclusively proved that hydroxychloroquine works in mild COVID-19. In hepatic impairment and renal impairment, one has to be cautious while using hydroxychloroquine. And there are some diseases like psoriasis or myasthenia gravis which can be controlled by use of hydroxychloroquine. As such, it's a more or less well-tolerated drug. However, nausea, vomiting, abnormal LFTs, or hypoglycemia may be encountered, especially when it is used in conjunction with drugs like quinolones, which may cause hypoglycemia. And as mentioned previously, hydroxychloroquine may diminish the therapeutic effect of remdesivir. So co-administration is definitely out. Pregnancy and breastfeeding, it may be used in this in people who are either pregnant or breastfeeding. So it is recommended for a total duration of 5 days. And as I said, renal impairment, no dose adjustment is required. While in hepatic impairment, we have to use it with caution, but again, no dosage adjustment has been provided by the manufacturers. So this is about the individual drugs. What I'll try to do is I'll just move on to the FAQs. So first is a COVID-19 patient is having prolonged fever beyond 6 days. So he is otherwise having normal saturation. So in this particular patient, would remdesivir be indicated? So the patient is still having fever. So the question is whether an antiviral remdesivir would help in this case. So the answer to this would be no. It is not. It is not indicated in mild COVID-19. Even those who are having persistent symptoms, it is indicated only in those patients who are developing low oxygen, that is, saturation is going below 94%, or the respiratory rate is climbing up over 24 per minute. The second is a patient diagnosed with COVID-19. Now, she has this patient has a low oxygen, so this patient is hypoxemia and is requiring oxygen at home. So, since should he be started on remdesivir at home? So the question is that that if suppose he's being treated at home, he has not been able to manage a hospital bed, so he's getting steroids and he's getting oxygen. So should remdesivir be used at home? So the answer to it is also no. That remdesivir, it has got some potential serious side effects. So it should always be given in a healthcare setting when the patient is being monitored. So it should never be given out of any hospital setting. It should never be given at home. So the third question is that a patient was admitted on day 13 with a diagnosis of severe COVID-19. And this patient is having, since he's having severe COVID-19, this patient is having a low SpO2. So in this particular subgroup, in this particular patient, would remdesivir be indicated? So the answer is that, that in this particular patient, remdesivir would probably not be effective because the patient is likely in the hyperinflammation phase. So if we know the three stages of COVID-19: early infection, pulmonary phase, and hyperinflation. So around about the 10 days mark, the patient progresses from the pulmonary phase to the hyperinflammation phase. So this is the time where the viral load is almost not there. The viruses have been cleared, and this is where the host inflammatory response, they are acting rogue, so they are causing more damage to the body. So at this time, beyond day 10, remdesivir would not help the patient. So this has also been included within the guidelines. So remdesivir is to be used only in those patients who are within 10 days of onset of symptoms. So that is something which we need to keep in mind. The fourth question is: a patient of moderate COVID-19 is off oxygen and fit for discharge, but he has received 4 days of remdesivir. Now, the total duration of remdesivir is 5 days, 200 first, followed by 100 for 4 days. Can he be discharged before receive the fifth dose? Now, this is again a problem in the setting where there's a lot of people waiting in the emergency, so the patient is otherwise fit for discharge, but he's just waiting for his fifth dose to be given. So, is it a good idea to discharge the patient? Yes. So it has been seen that patients who has been whose last dose of say remdesivir has been omitted, they fare pretty well. They do not come back. So it has been seen that only 3 to 4% of these patients, they have any problems whatsoever after being discharged. So the usual norm is that remdesivir has to be given for 5 days or discharge, whichever is earlier. For this particular patient, the patient can be safely discharged without the fifth dose. A COVID-19 patient, this is the fifth question. He is discharged after 7 days of hospital stay, where he had received the full course of remdesivir. He is having shortness of breath with hypoxia on exertion. So he has gone back to his home, and when he has resumed his daily activities, he is seeing that he's feeling out of breath. So he is having some remnant symptoms. So the question is that will remdesivir help in this particular patient? So again, this is not indicated. Remdesivir is supposed to be given for a total of 5 days. After that, there is no point in prolonging the therapy, and the patient has been discharged. So the patient is at home. There is again no question of giving remdesivir outside the healthcare setting. The sixth question is: the COVID-19 patient is on ventilator for severe COVID-19, and there has been some request for giving remdesivir. So should it be given? Would it help? So again, the answer to this is that the patients who are having severe COVID-19 and who have landed up on ventilator, they are the group who are least likely to benefit from remdesivir, because the number of studies, they have shown that only those patients who are on low flow oxygen, they would benefit from remdesivir in the form of less chance of death and hastened recovery, early discharge, but not in these patients who are on NIV or mechanical ventilation. The sixth question is: a COVID-19 patient is admitted with fever with saturation of 95% with raised inflammatory markers, right? So he has been admitted, he's in the hospital, and he's having some fever, saturation is normal, but his inflammatory markers, they've gone through the roof. So would remdesivir help in this patient, in this particular patient? So again, it would not, because this patient would fulfill the criteria for severe, for mild COVID-19. So in this particular group of patient, remdesivir is not indicated. The other side of the story, again, which we commonly encounter, that a COVID-19 patient has been admitted with shortness of breath. His oxygen saturation and his respiratory rate is normal, so it is less than 24, and saturation is more than 94%. But a CT scan, he comes with a CT scan which shows a severity of 17. So anything more than 15, say, it is severe as per CT scan is concerned. So would remdesivir be indicated in this particular group of patients? So the answer to this is again no. So all the trials, all the studies which have shown little benefit of remdesivir, it has been only in those group of patients where oxygen level has gone down below the normal level. In none of the studies, CT scan or X-rays or radiographs have been used as entry point criteria for treating patient. So it won't be right. So it won't be evidence-based to treat this particular patient whose CT severity is 17, but who's otherwise fulfills the criteria for mild COVID-19 with remdesivir. So my last two questions is the second last question is about a COVID-19 patient who's having fever on the 7th day. So he has been taking Favi Pyrovir diligently for the last 7 days. Now, since he's having fever, he wants to know whether he can continue it till 14 days. So the answer is again no. Favi Pyrovir has been not shown to be beneficial in COVID-19, even in mild COVID-19. So it should be immediately stopped because it won't help. And my final question is about, again, a COVID-19 patient who is having high-grade fever and mild cough, and his saturation is normal. So he wanted to try out twice a day of ivermectin. So would that be indicated? So again, the answer is no. The suggested dose is 200 microgram per kg once a day. So for a 60 kilogram patient, it would be 12 milligram once a day. Giving higher doses, giving for a longer duration of ivermectin it has not been shown to be beneficial. So increasing the doses, it would actually increase the chance of producing side effects in that particular patient, and probably it won't benefit the patient much. So its use in increased dose should be discouraged. So this is more or less my last slide. This is how I would like to summarize. So on the left hand column, we have the different antivirals. So the first antiviral remdesivir, indicated only in moderate and severe patients who are on low flow oxygen. It has got no role in mild COVID-19 patients who are in their home. And we know that it is an intravenous drug. So regarding favipiravir, it has got no role in COVID-19, right? Though it is an oral drug commonly available, but its use should be discouraged. Regarding ivermectin and hydroxychloroquine, so the guidelines which I talked about, they mention it within mild COVID-19. It may be used in mild COVID-19. Whether it would be beneficial, it's a little doubtful whether it would be beneficial, but probably they would not be harmful in the vast majority of patients. And they are one of those treatments which can be used at home. So a lot of patients prefer taking ivermectin or say hydroxychloroquine. So that is all I have to say. Thank you for your patient hearing.
Thank you, Dr. Animesh, for covering the entire topic and discussing all the available antiviral. I know this is a topic which can generate a lot of controversy, and there is a lot of, let's say, if I may put it, personal experience, and people have used it in different parts of the country are using different protocols, and many of these drugs are routinely being used as part of mild case management. Coming to ivermectin, I think the data there is very strong that it is not a magic bullet. If you look at the initial studies which were published, although their sample size was small because the studies were started in China and then the pandemic moved on, but they were all negative studies that did not show any benefit. Subsequently, the data which emerged from the US did tend to show some benefit in terms of decreasing hospitalization, although that data did tend to suggest that although the sample size was less, there was a trend toward decreasing mortality, but that did not really reach statistical significance. So I don't think we can really take that as being significant. But the hospital stay did come down in that study. But the large study done by the WHO, the Solidarity Trial, did not show any benefit, and that's why remdesivir is not actually in the WHO guidelines as a part of a treatment strategy. And that in the Indian guidelines also, it is only in as an emergency use, only in limited for only limited utility in moderate illness in patients who are admitted with falling saturation, inflammatory markers going up, and X-ray or CT showing infiltrates. So therefore, it's very important to remember this, and we must discourage early use of remdesivir. It doesn't show any benefit. There are patients who started taking getting remdesivir at home. All of this, I think, is of no use. There are patients who talk and say, should I take remdesivir because I've come in contact with the patient who is COVID positive? If there is some virus in my upper airways, then taking an antiviral drug will kill it. And therefore, now I should start it because the viral load is less and the drug will be more effective. So this is the type of logic a lot of patients tend to use, and sometimes even doctors tend to use that. I remember many months ago when we used to do EICUs, one doctor himself said that, I think I should give it on day one, even in patients who have just turned to positive, because it will kill the virus early and therefore it will make sure that the patient does not progress to moderate to severe illness. The data is not there as far as this is concerned. Even for favipiravir, now favipiravir is a drug which has got the DCGI approval for treatment for COVID-19. So that is something we already have based on some studies done in our country. But it is a drug which was again approved in Japan for influenza. As a matter of fact, after the H1N1 pandemic, this was actually improved for influenza, and there was some data which suggests that it may be useful in patients who are resistant to oseltamivir, that is Tamiflu. So in those who are resistant to oseltamivir, it was said that favipiravir may be useful, and it could be tried in Tamiflu or oseltamivir resistant H1N1 infection. It was again used, and there is a randomized control trial which has used it in Ebola and shown that it may be effective in treatment of Ebola also. But the data for COVID-19 is not strong enough. It has also been approved in Russia, and there also favipiravir is a drug which is used. But I don't think the data is strong enough, and this was discussed in great detail in the National Task Force and by the Joint Monitoring Group of the Ministry of Health and Family Welfare. And they looked at all the data, including number of meta-analyses which have come out over the last few weeks, and did not find the data to be strong enough to really recommend it as far as the national guidelines is concerned. The third drug is Ivermectin, and again, Ivermectin is used a lot. Started off with the trials from Bangladesh, which actually tend to show that it was useful and decreased the viral load. And again, in mild cases, it helped in terms of preventing people going on for moderate illness. But again, the data was not strong enough. Again, now there are a large number of meta-analysis and series available. Again, I would say the data is plus minus if you want my critical view. But there is some data which suggests that in mild illnesses it may be useful, and it was discussed in detail again in the task force, and they felt that it had a little bit of an edge and we should consider it, and that's why it has been added as a possible drug that can be used. It's not again recommended, but as something that can be tried for mild cases. And the same goes for hydroxychloroquine. Again, data is there to suggest that it may be useful, and therefore that has also been added into the guidelines that we may have considered hydroxychloroquine. 1 year ago, we promoted hydroxychloroquine a lot, even as prophylaxis. A weekly dose of hydroxychloroquine was promoted, and a study done by ICMR and a study from our own institute did tend to show that those healthcare workers who were taking hydroxychloroquine did have less infection as compared to those who did not. But subsequently, larger studies did not show it to be of much use. So I think prophylactic use is also something that has not been recommended. But currently, like I said in the beginning, we don't have a very good antiviral drug. This is something that many of us feel is needs a lot of research, because we did a aggressive research in developing vaccines, and we have now so many vaccines available. But I can't say the same as far as a good antiviral drug to really treat COVID-19 is concerned. We don't have a good antiviral drug. But luckily, it's also a self-limiting illness in most people. 85% of people have. It is self-limiting. No matter what you give and what you don't give, the patient will become all right. And that is why a lot of alternate medicines also seem to be popular. Because even if you were to give just paracetamol in symptomatic treatment, majority of patients should improve or will improve. And I think that's an important thing to keep in mind when we start looking at these drugs. So now I'll just again welcome all the panelists along with Dr. Animesh Ray, Dr. Anjan Trikha, Dr. Manish Suneja, and Dr. Neeraj Nischal. And I'll hand it over to Dr. Rajiv to really take the questions and sort of try and answer all the queries. I'm sure there's going to be a lot of debate as far as antivirals are concerned. And maybe Rajiv, you could start off by getting comments from the various senior faculty who are there on the webinar and see what they have to say.
Thank you, sir. Yes, so everything that Nimesh has tried to answer, unfortunately, still pops up as questions. Therefore, it will need to be reiterated a couple of times before people accept what you're saying as being true. So, could we begin with people on the panel and their experience on the use of any of these agents? Anybody on the panel would like to give their experience for both the both Ivermectin, Favi Pyrovir, as well as the remdesivir?
So maybe I'll ask Dr. Manish to start off because what was their experience with hydroxychloroquine and Favi Pyrovir, and
Thank
maybe
you.
remdesivir also.
Yes. So regarding SCQS, yes, we used it as a prophylaxis as was recommended last year. So initial data, observational data did show some protection among healthcare workers who were taking it as prophylaxis. That was showing a relative risk reduction of around 65%. But however, subsequently we know that it has not been shown to be effective in randomized controlled trials. So it's no longer being used. SCQS, we used it also as a part of solidarity trial, and we know we have a robust data set now from across various studies which have shown no benefit. In fact, the rate ratios has been more than one in all the trials where SCQS has been used. So SCQS really not found to be effective and not being used. Though the trials had some issues like use of SCQS was pretty late in the course of disease. Regarding ivermectin, Ivermectin generated a lot of interest when it was shown to have a very good EC50 values in vitro studies, which was shown to have very effective against the virus in vitro. But the concern was that a dose of 35 times the normal dose that we use is required. Now, if you look at subsequent studies, physiological based pharmacokinetic studies have been done, which shows that ivermectin is also concentrated in the lungs, 10 to 15 times, and that is in the serum. So it does get concentrated in the lungs. There is a theoretical plausibility because it is a broad spectrum antiviral effect. If you look at the practical aspect of it, as sir pointed out, few studies from Bangladesh, then Iran and some other countries, quality of evidence is low, certainty of evidence is low, but there's a definite, what they have shown is decreased rate of intubation and also mortality among these randomized controlled trials. But again, the strength of evidence is low. There's a high risk of bias in these studies and there's imprecisions due to the low sample size. However, when we weigh in the risk and reward, it has been recommended in the trial, in the protocol, and we have been using it in mild patients, particularly those who are having high risk factors for progression to severe disease. That is about ivermectin. Regarding favipiravir, we don't have enough evidence as much as even the evidence is lesser than that we have for ivermectin. So it is, and again, there's a pill burden. So many pills need to be popped in, side effects, hyperuricemia, and GI side effects. So that is something which we are not using, and it is not there in the national protocol as well. So these are the about the three drugs briefly.
Anybody else who's used? I mean, I'm sure everybody has used remdesivir. Everybody who's working on it. So, any experience that you would like to share? Do you think it works? When would you prefer to give it? Yeah, yes, sir. At Nagpur, Dr. Kushwaha.
So good afternoon, everyone. Nice presentations we just heard from the faculty at AIIMS, Delhi. Sir, as far as my understanding goes, the remdesivir or any antiviral for that matter would work best when the virus is replicating, because that would stop the replication and possibly, curtail the viremia levels that may occur in a patient. And that is where the whole seed for the inflammation response by the body lies. Now, in a case, I'll just give an example that the drug should be very judiciously used, possibly in the early phase of disease, not in everyone, but definitely in certain cases which are likely to go into a severe disease, multiple risk factors. For example, we had a case I won't like to name, the patient, but very high risk category patient who was morbidly obese, had undergone bariatric surgery long ago, was hypertensive, diabetic for long durations, maybe 20 years plus. And apart from that, he had IST as well, and was on medication for all the comorbidities, still obese, very obese. Now, this individual came back from Delhi after having contracted the infection and got diagnosed while in Nagpur, got tested positive, and he was put on Favipiravir by the treating physician. Then second day, I came into picture and we discussed the case with the treating physician. I advise that since it's a very high risk case and it's got many multiple risk factors, if at all he ends up in inflammatory phase, then we won't be able to save him. So it's better that if we have to treat him with antivirals, then we must go full throttle. So I suggested that we put him on remdesivir, and that was started on the second day of illness. And generally, the recommended protocols are, we all aware, 5-day regimen, which was found to be equally effective as the 10-day regimen. So we did the 5-day regimen, and till then his saturation, everything was normal. He developed a little bit of cough and maybe some chest discomfort in between, but at the same time, by the time his dosages were over, he did not proceed into any inflammatory phase, as all markers remained absolutely fine, and his oxygen saturation levels remained absolutely fine. He never went into any inflammatory phase, and he recovered without even giving steroids. And he never had to use any anti-inflammatory, and he recovered completely without any problems at 40 without any support of.
I think I'll ask Neeraj to comment on this. Although I think we really can't go by one case or as a personal experience, because one could argue that he would have recovered on his own even without getting remdesivir. We don't have evidence one way or the other, and we have enough randomized trial which would sort of not support that. And this is a lot of data which is also put forward by many physicians for other drugs like Favi Pyrovir. I remember one very senior physician in Mumbai presenting us cases and saying that, I gave this person Favipiravir and his X-ray cleared up, and he became much better. His saturation improved. So I just said, if you hadn't given it, also it may have improved. What is the evidence that it worked like that? And same thing is there for so many other patients, many with so many comorbidities. I mean, we've treated patients in their 90s with multiple comorbidities, and probably Neeraj can add on to that as to the role of remdesivir in such a situation.
Yes, sir. Thank you, sir. So even in the early part of disease, when we used to admit most of comorbid patients, even if they were mild, just anticipating that they might worsen. And we never used remdesivir in those patients because one, it was not available, and there was not enough evidence to use in such patients. And most of them recovered on their own. So this one example that he did not develop any complication. We have few examples where we started early, but still that patient land up with inflammatory response and requiring ICU care. So I will say the role of remdesivir, whether it's 5-day or 10 days, is equally ineffective. Not effective, I'm saying, ineffective. So some patients might benefit, as far as the stay is concerned. And when we talk about comorbidities, especially those patients who are on antihypertensives or those patients who have CAD, and especially on beta blockers, if we use remdesivir in such patients, then there is very high possibility that they'll end up in bradycardia, a pulse rate of somewhere around 40s. And anyway, we have to stop remdesivir. So remdesivir is not a very safe drug, I will say, for treating a comorbid patient, anticipating that this is going to prevent him from deteriorating further. In fact, it may do more harm. Just for example, I said those on beta blockers or those with CAD invariably land up with bradycardia. Though COVID is basically blamed for that, but our observation is that those who receive remdesivir invariably develop bradycardia in such situation. So I will say that we should be very judicious in using remdesivir in patients with comorbidities. it should not be projected that all comorbidities should be considered for remdesivir for preventing further deterioration. In fact, it should be other way around, that those with comorbidities should be given remdesivir if required only after ruling out all other possible complications. And as far as favipiravir is concerned, we do see patients who get admitted with us because of moderate and severe disease who have been started on favipiravir. And most of them have GI complaints. Most of them have increased uric acid, which may actually be contributing to their non-specific myalgias, which they are complaining. So, and again, favipiravir also may cause bradycardia. That is something which is being ignored at the moment. So all these drugs which are being promoted in such a strong way should be actually looked more critically, and the data regarding their side effects should be collated from all the centers. And in, just anecdotal report of one patient improving because of this in a comorbid condition should not be generalized at all.
Thank you, Neeraj. I think Dr. Kushwaha wants to add something to that.
I do agree with that the single case cannot be the ground for maybe promoting a particular therapy. But at the same time, we do understand that the use of drugs in COVID, especially antivirals, and second drug is anti-inflammatory, which is steroids mainly, are to be used in that particular phase of the illness where he is in viremia and the other person is in inflammatory response. If we switch these drugs, it's going to be harmful, that we all know. So having said that, is it not prudent that rather than the clinical staging of the disease, the timeline of the disease is again very important when we are choosing about drugs which we are going to use in these cases?
I'd just like to add that 85% of people will improve without this thing, and you'll have many mild or asymptomatic people. You will probably cause more liver damage if you started giving to all of these patients, saying that everyone who is COVID positive should therefore be given remdesivir. That makes it totally, I don't think it's a logical statement. And we should go by the data. There are so many trials now. For 1 year, there have been so many trials on remdesivir, and the evidence is accumulated only for those with moderate illness with a fall in oxygen saturation. So I think we could move ahead and maybe take the subsequent questions. And I would request Rajiv to do the same.
Right. So I think I agree that this discussion can go on. So this clearly was one of the first questions that came up on the chat also, that should we be timing it based on the duration rather than the stage? And we've addressed that in the last little bit of discussion. The other question is more theoretical than practical, but does anybody have an opinion of why is there no change in mortality and morbidity? Can you speculate? I mean, I know you don't have the data. That's what the study shows. But is there any could there be a theoretical explanation of why did the drug not show mortality and morbidity benefits? Is it study design, sample size, or something else?
Animesh, you want to answer that?
It's a very interesting question, right? So my understanding goes that for any particular drug, there are some soft pointers and there's some hard pointers. So the hard pointers, they usually pertain to mortality. So as far as COVID-19 is concerned, we are primarily concerned about the mortality benefit from any particular drug, right? So for a drug, if the drug is really that effective, then it should lead to decrease in mortality. So since remdesivir has not been shown by any of these studies to be effective as far as mortality is concerned, so I think the plausible reason would be that it's not a potent antiviral against COVID-19. It's not a potent antiviral. It is not leading to dramatic decrease in the viral load and clearing the virus from the patient's body, and so leading to a significant change in the outcome. But probably it is doing something, probably less than perfect benefit is occurring due to remdesivir, due to which there is a decreased time to recovery as shown in the ACT-1 trial, which was a US-based trial, which was a very good placebo-controlled double-blinded trial. So I think that may be the plausible reason that why we are not seeing any mortality benefit due to remdesivir, but yet some parameter wise, it is indeed showing some benefit.
Okay, thanks.
If I may just add, there were many studies, there were 2 or 3 things here. Studies were done to look for mortality benefit, but the data did not show that. That is one. Many trials did not achieve that much of a sample size. The initial trials, which were published from China, were interim. They had to do an interim analysis because the cases came down so dramatically in China that they could not achieve the sample size, and therefore they published the data with whatever sample they had. But whatever data has been accumulated, whether it be the ACT trial or the solidarity trial or data from China, was not able to show a significant mortality benefit.
Right, sir. The next question we have here is more about availability of the drug. And so if you are short of drug, is giving some drug better than giving no drug? Say you have 2 vials, you have 4 vials, but you're not sure that you'll get more. So should you give some or should you not give any unless you can give a full course?
So Manish, what is your take on this? If you have only 3 vials of remdesivir, will that work instead of, so you give a loading dose of 200 and you just say that's enough?
So that's very difficult. So one really has to have 6 vials when we are planning treatment for a patient. A suitable patient is more important to identify a suitable patient, and we have to have at least 6 vials to give to the patient. Yes, obviously, if the patient improves earlier, is weaned off oxygen, we can very well stop the remdesivir. But to begin with, we should always have that leeway in hand that we need to have 6 vials for a patient. But yes, it can be stopped earlier if patient has improved.
I'll just move ahead and ask Neeraj, 5 days versus 10 days. What is the literature and what's your take?
Again, WHO has clearly said that this is not an effective drug. So I will say that 10 days remdesivir is as ineffective as 5 days remdesivir. And this is what we have observed. Agreed, we have not been able to generate that much evidence, but eminence and evidence is there is very fine line. Eminence which become published become evidence. But over last 1 year, we have observed that remdesivir has in no way changed our treatment strategy or the outcome of the patient. So if somebody has only 3 vials of remdesivir, I will say if the patient is requiring oxygen, then judicious use of oxygen, steroid, and maybe anticoagulation is going to save his life. And they should not waste their energy on procuring the remaining 2 vials of remdesivir. And that should be something which should be emphasized again and again, because the social media platform is full of please, okay, arrange remdesivir for me, a drug which is not life-saving, and still people are feeling as if it's life-saving. And I'm saying this because I keep on receiving messages from people, please arrange remdesivir. And in spite of saying it's not going to save your life, life-saving will be only these 3 things. And people don't actually respect that thing. So this is something that should go clearly. Ki 3 din ka ho, 5 din ka ho, it's not going to make any difference. It's just oxygen, judicious use of steroid and anticoagulation that will save life.
Yeah, I think it's very important to understand what is the data. The data for oxygen, data for steroids given at the right time, and data for giving anticoagulants is the strongest. There is really no strong data as far as remdesivir or other therapies are concerned. Even for plasma therapy, for convalescent plasma, the data is not that strong. So it's important to keep that in mind.
Nigrims wanted to come in.
Sir, we are more comfortable with the steroid and the heparin rather than the remdesivir. We are using the remdesivir because we do not have any other medicine, and many times it is a pressure. And as it is there in the protocol, many protocol, that's why we are using. Otherwise, we didn't see any difference. And just because it's there in the protocol, many times we have to use it. Otherwise, I do not see any difference. What is actually working is the steroid and the heparin.
So even in the protocol, it's mentioned as a separate block only to be given as limited as something which has not been shown to be much benefit. If you look at the protocol, the 3 main things in the protocol have been basically oxygen, along with the steroids and the anticoagulants. The other thing, that is anti-IL-6 drug tocilizumab, convalescent plasma, and remdesivir, is actually in the box below, which has been done that because these are of unproven utility, but may be tried in limited situations.
Yeah, so the AFNC, Dean wants to come in.
No, I just have a question that if both AIMS as well as NEGRIMS are so certain that remdesivir is really not working, why aren't we really sending this message across more strongly that, look, this is not going to work. We need to send this message to the medical professionals who are prescribing it rather than to the lay public. And maybe we should focus on that a great deal more than what we are doing right now.
Yeah, I agree with that, and we're trying to do that. I think even if you look at the previous guidelines and the current guidelines, remdesivir is now in the box below rather than in the main criteria. And gradually one is looking at how do we sort of position it. The problem is that it's something that can be done only over a period of time because it has become so acceptable. Both tocilizumab and remdesivir have become so much sort of let's say part of layman's acceptance that getting it out and getting it out of the system is going to take some time.
I think what Neeraj said about eminence-based medicine is so important, that the eminence here is driven by your social media followers. How many followers you have decides what treatment a COVID patient gets. Doesn't matter what your qualification is. We'll carry on with the remdesivir story, and the next question is remdesivir in first trimester of pregnancy. So pregnancy use for remdesivir.
Dr. Animesh,
Yeah.
what is your take on this?
Yes. So remdesivir has been tried in in a subset of patients with having pregnancy, and the initial reports, they show that it may be safe. But as of now, we are going by what the manufacturer is saying, and till now, I think there isn't enough data to say that remdesivir can be used either in patients with pregnancy or breastfeeding. So we are avoiding it. So we are not giving remdesivir to patients who are either having pregnancy or breastfeeding, but we understand that with accumulating data, probably that can change in the future. But as of now, no, not to be used in pregnancy.
Yeah, so I'll just add two things here. One is that, as we've been saying, the data for its utility is not strong enough one way or the other. And since we don't have safety data, we have to be careful. However, what has been mentioned is that at times you can take a risk-benefit analysis, talk to the patient's attendants, and if getting their consent, can at times use it in pregnancy. And we know that there are times when it has been used. But as we've been saying, the evidence for its use otherwise is not that strong. So giving it in pregnancy would even be something that we have to be even more sort of reluctant to do.
So moving a little bit away from remdesivir, and this is more a query on Favi Pyrovir now. So assuming the patient is on home isolation and the fever is persisting and the patient hasn't yet received Favi Pyrovir and the fever persists on day 6, would you consider giving Favi Pyrovir now on day 6, home isolation, persisting fever?
So Neeraj, do you want to answer that question?
Again, we don't use favipiravir because we are not sure whether it works or not. So as per the home isolation guideline, if fever persists beyond 7 days, beyond 5 days, one can consider starting budesonide, inhalational budesonide, based on the recommendation of the person, the care provider or the doctor in whom he or she is in contact with. And beyond 7 days, one may consider, depending on what the treating physician feels, whether the patient requires oral steroid or not. But at the moment, we are not prescribing favipiravir, and I don't know whether it's going to work in that patient after 6 days or not.
Okay. Any other comments from anybody on the panel on favipiravir at late initiation in home therapy? So that's not recommended. Nobody recommends that. All right. Moving a little bit away from antivirals, but there's a question here about steroids. I suppose we can take it. This is about using pulse steroid therapy in severe COVID. Does it have a role?
So this is regarding pulse steroids in severe COVID, the pros and cons. Maybe Manish can sort of touch upon that to begin with.
So so we have a subset of patients, severe COVID, who are not responding to steroids. The usual dose that is prescribed protocol, that is 1 to 2 mg per kg of methylprednisolone. Now, some people have used it in their practice, and also some trials are being initiated. But current level of evidence, we do not have sufficient evidence for high dose pulse steroids in COVID-19 per se. And whatever experience we have seen is that patients who have received pulse steroids, and they are the patients who are going to require prolonged ventilation, maybe weeks. And in our setting, in Indian setting, we do get a lot of ventilator-associated pneumonias. So giving high dose of pulse steroids then many times we have seen patients land up with us with very bad ventilator-associated pneumonias with multi-drug and extremely drug-resistant bacilli. So that is a concern in Indian setting using high-dose steroids. As of now, we do not have sufficient evidence for the same.
I would agree with that, although I know there are many centers which tend to use pulse methylprednisolone. I remember many months ago, one doctor telling me that since he was not able to get tocilizumab in all those patients who were having a cytokine storm based on the deterioration and the markers, he was giving them pulse therapy. And my fear, as Manish has said, is that many of them land up with opportunistic infections, whether it be VAP or secondary bacterial infection, or even a subsequent fungal infection. So one needs to be very careful about giving such high dose pulse steroids. I don't think there is sufficient data right now, but if anyone in the panel would like to add on to this and from their own experiences, they would be welcome.
So would anybody
did use it in a few cases, but overall the outcome was pretty poor. And rather than the patients dying of VAP or something like that, it was probably the MODS that took them down. So it was probably initiated quite late and the MODS just took them down. So the outcomes were uniformly not very good.
Okay. Yes, ma'am.
We are using like methylprednisolone as the pathophysiology is very clear and the beneficial role of the steroids are very clear. Only, sir, in few cases we are finding that leukocytosis is very high. To the tune of, I have seen the patients going the WBC count to be higher than 15,000 and 20,000. So we have to be very careful. It is not because of the infection only, but it is also because of the use of these steroids. So we have to have a very judicious and a short-term use of these steroids and not a very long-term use of steroids.
Okay. I'm going to continue on the remdesivir story here a little bit on a few more questions on the other side. So two questions. One, COVID not proven on RT-PCR, symptoms are very characteristics. Can we give remdesivir? And the second question is the use of CT scans in determining when to give remdesivir. So kind of linked.
So maybe Neeraj can take them up.
So again, regarding CT scan, first of all, I will take that aspect because CT scan is something which is being done on day 1, day 5, day 7, day 11. But one has to remember nowhere in the world CT has any role in the diagnostic and prognostication of the patient. No management decision is being taken based on the CT finding. So it's the clinical finding of the patient, their oxygen requirement that determines what type of therapy is going to benefit the patient. So CT has no role whatsoever in deciding whether a patient requires remdesivir or not. In fact, CT has no role whatsoever in deciding the treatment protocol. And the first question was, sir?
The question was that RT-PCR is negative. You don't have microbiological proof of COVID.
Yeah. So again, like we said, remdesivir, the role of remdesivir is controversial in itself. So if somebody has RT-PCR negative, repeated RT-PCR negative, we have to also keep in mind other form of atypical pneumonia as well. So we will not recommend those patients to be given remdesivir because one, we have not proven it to be COVID-19, and second, we don't know whether it actually works or not. So at the moment, it's not recommended.
So again, stretching this question further, then would you use biomarkers alone as the indicator for remdesivir?
So biomarkers only shows inflammation. So if inflammation is increasing, we are more going towards the cytokine storm of a sort of thing. Like, and again, just because a marker is raised doesn't mean that patient is going to land in cytokine storm. So one has to take these markers in context with the clinical setting of the patient, whether the patient has started showing signs of deterioration in term of oxygen saturation, whether the patient has become tachypneic, breathless, or is he finding it difficult to walk around and getting breathless. So these all aspects have to be taken into account before interpreting these markers. These markers will not tell you immediately that this patient is going to become sicker with time. It's not like that. So we have to monitor patients' clinical symptoms more closely.
Madam, you wanted to say something.
Yes, sir. I wanted to say that even if the first RT-PCR is negative, in such patient, I think we can repeat RT-PCR after around 48 hours and then decide the further strategy for management, whether he is COVID positive or negative.
Right, Animesh, yes.
Yeah. So I mean, I agree with what Madam has said and what Dr. Neeraj has said. So, in our COVID center, we are admitting only patients who are COVID RT-PCR positive. So we are not encountering that problem. But I guess in some places where they are admitting a mixture of COVID-19 and other patients, so if the RT-PCR is once negative, twice negative, and the CT scan is suggestive of COVID-19. So if there is something called a CORAD score, if it is 4 or 5, then that might be an indication for starting at least some of the treatment against COVID-19. Because the RT-PCR is repeatedly negative, and the CORAD score is high, that may be taken as suggestive of COVID-19, and the patient should not be denied of, say, anticoagulants or steroids, at least for treating this particular patient.
I'll add to this. I think it's important to keep in mind, and that's why we're also looking at what we call a syndromic approach to diagnosing COVID-19. Because when we start looking at management strategies in smaller cities and towns or in rural India, you may not have the RT-PCR available. So one should get an RT-PCR done whenever it is possible, repeat it if it can. But you can also look at a syndromic approach, and if you have a very high positivity rate in that area, you should presume that this may be COVID unless proved otherwise. A CT scan may help you, but we must remember it just shows interstitial pneumonia, which has more of a peripheral distribution, if I may put it that way. But many other infections can show that. I remember one presentation where this patient actually on lavage turned out to have Legionella pneumonia. His RT-PCR was repeatedly negative, even the lavage was negative, and it turned out to be Legionella which responded to treatment rather than COVID-19. So it's important to keep that in mind, that you can have atypical pneumonias also in the current time. Everything is not classically COVID, but if your positivity rate is high, if the clinical profile is very suggestive, I think you could do that. What we've done here is we also have what we call a COVID suspect area. So because it won't be correct if you put such a patient who may be COVID negative into a COVID positive ward. So we have a COVID suspect area where people who are COVID RT-PCR negative but are definitely having features, clinical radiological profile very suggestive of COVID, you can keep them in that area and treat them if need be, with steroids, anticoagulants, and other supportive treatment. But it's important to keep that in mind, because remember, RT-PCR positivity is also only around 80%. You will still, it's not a test, it is highly specific, but sensitivity is not that much. So you can't say that your RT-PCR will pick up every case. You may have some patients who may be having COVID, but your RT-PCR will be negative. And it may not be right to deny this patient treatment, but you must keep testing. Some people even argue that if the patient deteriorates and you have the facility, or is intubated, or you can otherwise, you should try and take secretion from the lower respiratory tract, like a lavage, and try and send that for RT-PCR. But having said this, I think we must remember that you will have some patients who may not have a positive RT-PCR. You may also have another scenario. The RT-PCR report is taking time. And sometimes in some places, the RT-PCR report comes after 3-4 days. Can you wait for 3-4 days if the patient is not improving? Again, you will have to make a presumptive diagnosis based on the clinical radiological profile and start treatment and wait for the RT-PCR report. So keep that in mind. I don't think we can say that unless you have a positive RT-PCR report, you can't treat. You can develop a strategy, and that syndromic approach to treating COVID-19 will have to be developed as we start going down to smaller towns and cities, because they will not have that much of capacity. And if we have a huge outbreak in that area, I don't think we will be able to really provide only RT-PCR based tests. The only other solution that I can think of is a rapid antigen test. The rapid antigen test will have a high positivity in such a situation, and it will give you a result quickly. So if you are having areas where your positivity rate is high, especially in rural India or small towns, rapid antigen test would be very useful in such an area, because it will give you a diagnosis within a few minutes and would decrease the load on the RT-PCR lab.
So we'll move a little bit away from remdesivir now. There are a couple of questions on the use of oseltamivir and also antibiotics, doxycycline and azithromycin. So what is the status on using these agents? We don't have a separate section on antibiotics, so maybe we could take those two questions here.
So Manish, would you like to answer that role of doxycycline and azithromycin?
So yes, we talked about, I think, oseltamivir and antibiotics. Oseltamivir, yes, when we have influenza, we will need that. So a prudent approach may be to have a subset of the samples being tested for COVID. We keep surveillance for influenza occurring in our patients, and particularly in the seasons, because it varies from in different parts of the country. So maybe we can test 5% of our samples, and we come to know whether influenza is coming in our patients, and if so, yes, oseltamivir may be used. But short of that, oseltamivir as such for COVID is not required. Regarding antibiotics, again, initial studies did show some early clearance of the virus from the throat by RT-PCR, but then we knew that this is not really a marker, a hard clinical point. And since then, many studies have been done. I don't think any of the studies have shown benefits of antibiotics per se. Antibiotics use as a blanket therapy in COVID patients has not been shown to be of benefit. So as well, it is not in any of the protocols that we use. So we are not using antibiotics per se in a blanket fashion.
Yes, sir. So again, moving away, this is regarding oseltamivir and influenza. My impression was that there are now a number of papers which have said that oseltamivir actually has no benefit in influenza. So are you still recommending the use of oseltamivir for influenza patients?
So oseltamivir, we are talking about at this point in time, COVID, no. But yes, oseltamivir in influenza, it is still there. So given as per the national protocol, even in influenza, oseltamivir still continues to be used. So under that circumstances, we would recommend oseltamivir if we have an influenza positivity, a substantial positivity in our samples which are being tested for COVID as well. So because it can quickly have an outbreak as well. We have to realize if one patient in the ward is positive, if even 1 or 2 samples are positive, it can quickly spread in that closed area to involve other patients who are nearby. So under those circumstances, yes, the treatment would be warranted.
So if I just add on to that, the national guidelines do mention that you should use oseltamivir, a neuroamylase inhibitor, as far as treatment of influenza is concerned. The data is not that strong. There is a large number of trials which show that it may or may not be that effective, but it is still recommended to prevent or decrease the chance of it spreading to other people. I remember at that point in time when one looked at the data, we said that if you take oseltamivir, you'll become all right in 7 days. If you don't take it, you'll become all right in 1 week. So this was the type of thing that we used to say. So it's something that we need to keep in mind. But in an outbreak situation, when you want to limit the degree of spread in a community, it may have a role. So it should be considered in that situation.
There are a large number of questions on the same issue of early use of antivirals. We've addressed it repeatedly, but maybe I'll leave it to sir to sum it up at the end. Why repeatedly everybody wants to know why can't we give antivirals on day 1? So I'll leave it to you to summarize at the end of it, sir. But that's something that I think you'll need to say once again at the end of the seminar as to why you can't give antivirals on day 1 to everyone. We'll move on to.
I'll ask Animesh to do it or Manish to do it.
Okay, we'll do that later.
If I can add one point, because just we are talking so much about remdesivir, now studies have shown, in vitro studies have shown that there's rapid selection of subpopulations of the COVID, SARS-CoV-2 virus, which are resistant to remdesivir. So we also need to keep in mind, remdesivir is not a great antiviral. We know it is not something going to suppress 80-90% of the virus. It would be suboptimal. Plus, it has been shown now there's rapid selection of populations, which subpopulations of the virus, which are resistant to the drug.
Right. So we'll do that as a summary at the right end, because I think that's a message that needs to be repeated because it comes up every second or third question. Meanwhile, is there a possible role of reusing remdesivir in a second infection in the same patient, reinfection in the same patient?
Okay, if it's not useful in the first case, I'm not sure whether it will be useful in the second case, but maybe Neeraj can, who is a great proponent of remdesivir, can answer that question.
So again, sir, as you said, we are not sure even for the first infection, and we are talking about mutants and all. We don't know whether this remdesivir is further going to aggravate that situation, as Dr. Manish had just mentioned, because of rampant use of antivirals, which may have suboptimal effect on SARS-CoV-2, may actually lead to selection of mutants, which may cause more problem. And that's one important reason why this should not be used. And if it is not effective in the first infection, then I don't think it should be used in second infection as well.
We have a lot of questions on topics other than antivirals and remdesivir, and I just like to repeat that what we do every day is that we avoid questions which are not specific to the topic today, because we have webinars covering each topic. So we're intentionally not taking certain questions on tocilizumab, on steroids, because they've either been covered or will be covered. We have a session on IL-6, I think it's tomorrow, that's IL-6 inhibitors and other drugs. So we'll take these questions at that point of time, and we'll stick to antivirals today. So we talked about antivirals in pregnancy. What about children? Are they okay to use antivirals in children?
So Animesh, what about antivirals in the pediatric age group?
Right. So, as I said that, they have to be used above 12 years and above 40 kilogram of weight. Now, they have also been used in pediatric patients whose weight is more than 3.5 kg. So between 3.5 kg to 40 kg, it might still be used, but it is a part of, again, EUA, as it is in United States of America. So emergency use authorization is there. So the data and the safety, they are not fully substantiated. So between this bracket 3.5 to 40 kg, it may be still be used, but only under EUA. So it is incidentally, our AIMS New Delhi protocol, pediatric protocol, they also mentioned the same thing, that they can be used in this particular weight bracket.
A very interesting question here. Can I be sued if I don't prescribe Ivermectin, or if I don't prescribe Favi Pyrovir? What is the what would my medical legal liability be if I don't prescribe one of these agents? I'm not sure anybody will give you an experience-based answer on that. It could only be a theory-based answer on that.
So I don't think there is one way or the other any strong evidence that you can be sued, because it's not a drug which can make a big difference. So I don't think that is there. I'd just like to add on to what Animesh had said for the previous question. If you go on to the ministry website or AIMS website, we already have guidelines for management in the pediatric age group. And in that, remdesivir is also mentioned according to body weight. If it is really required in hospitalized patient, how much is the dose of remdesivir that you can give? So the Indian IAP has come out with the guidelines, and so has the Department of Pediatrics at AIMS for managing children with COVID-19, because this time we're seeing it in the younger age group also. So it's worthwhile to have a look at those guidelines. If you're not able to get them, just let us know. We'll have them sort of emailed to all of you so that you can have a look at the pediatric guidelines, which have just come out, I think, about 10 days or 2 weeks ago, as far as managing children is concerned, with the same protocol that we use for adults, mild, moderate, and severe, and what is the treatment for children, and the dose that has to be given as per body weight.
The next question is on adverse effects of remdesivir. So a patient with persistent bradycardia and hypotension in somebody who's already completed remdesivir, how long can the side effect last, assuming it is drug alone?
So Animesh?
So so the package insert, the Veklury package insert by Gilead Biopharmaceuticals, it gives us some details about the the incidence and the duration of side effect. So it is said that commonly the side effect occurs after a median duration of 1 to 2 days of use. So if you are using it for 5 days, so probably by the second or third day, the effect would come by. So having said that, it does not mention that for how long it is going to be there, but the judicious thing to do is, if the patient is having some cardiac side effects, so either it is arrhythmias, bradycardias, or cardiac arrest like situation. So the package insert mentions that there has been an incidence of around 4% atrial fibrillation in the arm getting remdesivir as compared to the as 2% as compared to the arm not getting remdesivir, and bradycardia was around 1% in each arm. So if you're indeed encountering such side effect, so it's a good idea to stop the drug and not use it further, especially when you're not sure whether this drug itself would be making much of a difference, because there are other drugs, steroids, anticoagulants, oxygen, and other supportive measures which can be pretty effective for that particular patient.
If I can add here, so how long does it last? So around 3 half-lives that we expect, so around 3 to 4 days post discontinuation of remdesivir. Practically, what we have seen, the bradycardia lasts for around 3 and sometimes up to 4 days, which then reverts back to its normal baseline rate.
There was something you wanted to say, madam.
Yes, I agree with Dr. Manish, because we have also seen bradycardia to the tune of around 35 or 30 like that. And by the time third and fourth day, it improves. And most of the cases, of course, all the cases were the sinus bradycardia only, no other arrhythmia. And they responded after the remdesivir is improved. They say it is maybe because of remdesivir itself, or whether it is the direct effect of the virus on the heart. It is very difficult to say.
So a continuation on the adverse effect is another question that has just come up, is atrial fibrillation as well. So is that also associated with use, or is it just a part of the syndromic manifestation?
So Neeraj, what is our experience? We've had some experience on this.
So mostly we have encountered is bradycardia in most of the patients, which usually reverts in 7 to 10 days after stopping remdesivir. And only 2 patients, as far as I remember, had atrial fibrillation, but they had prior atrial fibrillation as in their history. So the disease or the drug, they usually, what we have seen is bradycardia mostly, and few patients have had few MI episodes. But was that because of disease or drug, or because they were at risk of developing this type of VA is difficult to say. But yeah, bradycardia, to best of my knowledge, is the most commonest manifestation of side effect.
And finally, I think the last question that we have before we wind up is there any way of judging that the drug is working other than just clinical parameters? So maybe are there biochemical parameters or imaging parameters which could tell you that the drug is working and you want to continue it, or is it just a clinical evaluation?
Okay, Animesh, can you answer that? That how do you assess the efficacy of the drug once you start it?
So, judging the individual effect of a drug probably is not that is not possible, because whenever you are remdesivir, we are using remdesivir, it is usually in patients who are requiring oxygen, and they are invariably getting steroids, anticoagulations, and and other supportive measures. But for any patient, how do we judge whether a drug is working or not, whether the whole treatment protocol is working or not? That is again subjective and objective. Subjective is obviously what the patient says, how is feeling better, breathlessness getting better or not. Objective is by some signs, respiratory rate, saturation, pulse rate, oxygen requirement. That is important. Next is biochemical. Some inflammatory markers, CRP, ferritin, IL-6, they might help. But what I've seen in my experience, that sometimes they are they move in different directions. So sometimes they end up confusing you. And obviously x-rays, if you're doing x-rays, they can also kind of help you in understanding whether the infiltrates they are getting better or not. So I think sum total of subjective, objective, biochemical and radiological parameters helps you in understanding whether the patient is getting better or not.
Thank you. So we've reached the end of the questions that relate to remdesivir and antivirals. We've also reached the end of our 90 minutes. So maybe you'd just like to sum up, sir.
Thank you very much. I'm not sure if any of the panelists would want to say anything before, as far as, because this is a topic which I think is the most controversial among the ones that we've had in our talks as of now. And that is basically because there's so much of opinion that goes around, and we have this whole WhatsApp messaging and other so-called databases which tend to suggest that A is better than B, or B doesn't work and C should be given. I think the whole issue is to understand that very often you just need to look at the evidence, and the evidence is very strong that supportive care is something which works a lot, and you must provide good supportive care, whether it's management of fever or symptomatic improvement. Second is, of course, the issue of trying to really monitor patients closely to pick up those who are deteriorating. So rather than rushing on starting drugs, I think the two important thing is supportive care and close monitoring that is required in mild patients, so that you can really pick up. You must develop a strategy of seeing how can you be able to differentiate between those 85% who will get away without much problem, and those 15% who will create the problem of having to be rushed to the ICU or to your ward, who need a high flow oxygen or whose saturation is dipping. So I think the focus should be on trying to really monitor your patients who are in home isolation or at home closely, rather than giving them a whole big list of 10 or 15 drugs to take, knowing that they are really not going to work. Second important thing, of course, is to really understand that the pillar of treatment are, as Neeraj said, basically oxygen, steroids when indicated, and anticoagulants. All other drugs have limited role. And like I said in the beginning, we really honestly don't have a good antiviral drug against COVID-19. Let's admit that, and hope that in the coming months we have good research which gives us a good antiviral drug. But as of now, whatever we're playing around with are repurposed drugs which have limited or no use. So let's accept that and say that, okay, we don't know how useful they are, but the data doesn't show that they're very useful. And therefore, to promote them as, game changers or magic bullets or something which will make a huge difference, and therefore promoting a black market for these drugs, is something which I think is not right. We are already aware that all of these drugs get sold for huge amounts. This includes remdesivir, it includes tocilizumab. Someone told me that a patient gave 4 lakh rupees for one vial of tocilizumab 2-3 days ago. Now, I couldn't even believe that it's going in the black market for something like 4 to 5 lakh rupees for one vial. This and the drug where we are not sure how beneficial how useful it will be. Same is happening for remdesivir. So I think we must be conscious of the fact that these drugs are not really that useful. By really giving a big hype to these drugs, we are promoting a whole sort of wrong market, if I may put it that way, which is not right, and therefore we must really promote the rational use of drugs, look at the evidence, and then push for it. After all, many patients became all right and recovered even before remdesivir came into the market, or it was available in our country. It wasn't that at that point in time we had a much higher mortality than what we are having right now. You could look at the data based on pre-remdesivir and post-remdesivir, and you will find that there was really no difference in terms of how the patients did in terms of mild to moderate or severe illness. So I think the data is not strong enough for us to really push that aggressively for any of these drugs. And the responsibility lies on all of us as I would say regional and state centers of excellence to try and percolate this information down to smaller towns and cities, that they understand that these drugs are not the magic bullet. We are not focusing ourselves on the right thing. Supportive treatment, symptomatic treatment, monitoring patients closely, picking up those 15% who will deteriorate, and aggressively treating them with the 3 things that I mentioned, I think will go a long way in saving lives. And that's what I personally feel. Anyone in the panelists who would like to give any comment, more than welcome.
I think everybody agrees with what's been said, sir. It summarized everybody's viewpoints quite completely, that we seem to have an overuse of remdesivir and too much of Twitter and WhatsApp driving remdesivir use rather than physicians and clinical decisions. Thank you everyone for being here again, and we will meet again on Monday. And this time it's going to be anti-IL-6 drugs, so covering tocilizumab and other ways in managing severely ill patients in the ICU. So thank you once again, everyone. We'll see you at 3 p.m. on Monday.
Thank you. Thank you very much. Thank you.
Thank you, sir. Thank you.
Thank you.